Hi, welcome back to IU Radiology Case of the Day. My name is Nick Kuntz, and I'm a neuroradiologist and head and neck imager here at Indiana University School of Medicine, and I'm back with another interesting brain imaging case of the day. So as always, I'd like to start out by making the statement that all of the educational content found as part of this learning module has been completely de-identified in order to protect patient privacy. So the history for today's case is that of an elderly man. Age is not that important other than to say he's sort of fits in that over 65 age group, and he presented with altered mental status. So I've got three images for you to take a look at. Image on the left is an axial 3D flare. The image in the middle is an axial susceptibility weighted image. Those two images were obtained same day, same time, but the image on the right is a follow-up scan. This is an axial 3D flare. This was performed exactly, or more or less, 2 years after the initial scan was performed. As you can see by matching up the sulci and the gyri, these are effectively at the same slice. Okay, so take a look at the images again. Axial 3D flare on the left, axial susceptibility weighted imaging scan in the middle. Those were obtained on the same day. And then the image on the right is effectively the same slice, axial 3D flare, but performed approximately 2 years later. So let's take a look. First up, the flare imaging. This was at time of presentation. And what you should notice there are patchy and confluent areas of signal abnormality, denoted here by the yellow arrows. And these tend to be found in the subcortical regions. You can see a lot of subcortical edema. It seems to be sparing the cortex, so it has a look of vasogenic edema. And then it also extends down deep into the corona radiata. So it's really sort of involving the white matter tracts, and some of these areas are really confluent. Next up is our susceptibility weighted imaging. And you can see that we have numerous small foci of gradient susceptibility. We have these peripheral, mainly supratentorial black dots. Now granted, I'm not showing you the posterior fossa, but for what it's worth, this was sparing the posterior fossa. But we have all these little foci of blooming artifact. You can see denoted here by the yellow arrows. I don't have an arrow pointed at each and every one, but lots of dots out in the periphery, mainly subcortical, maybe a few are out in the cortex, but mainly subcortical, supratentorial, peripheral distribution. And you can see some of the larger ones. You can see the blooming artifact where it's sort of warping the magnetic field around it. So here's where it gets interesting. 2 years later, we have the axial flare, and you can see there's really been a substantial reduction in that signal hyperintensity. Sure, we have some persistent patchy flare signal within the corona radiata, but it's much less confluent. That edema has really sort of dried up. So, put that all together. What's your diagnosis? And what do you think's been the interval treatment? So this is a case of cerebral amyloid angiopathy related inflammation. And this is a rare, or at least uncommon variant of a somewhat uncommon entity, and that's cerebral amyloid angiopathy. And so really what the hallmark of this particular variant of cerebral amyloid angiopathy is that marked inflammatory response. So in conventional cerebral amyloid angiopathy, we have beta amyloid that gets deposited in the brain, and that leads to having very fragile, almost friable vessels that are prone to rupture. So these patients have recurrent bouts of hemorrhage. Oftentimes it's sort of these peripheral, supratentorial, punctate, subcortical, maybe even cortical foci of microbleeds. But it can also be large lobar hematomas. They can present sort of with a spontaneous parenchymal hematoma. You can get subarachnoid hemorrhage with it as well. But the difference between that and the cerebral amyloid angiopathy-related inflammation is that with the inflammatory variant, these patients get either a perivascular inflammatory cell infiltrate, or they even get a transmural angiitis, almost like a vasculitis involving the vessels, and that leads to the edema like we saw in this case. And if you were to give contrast, you may even see some enhancement with this. It really looks like a robust inflammatory process. Just like in regular cerebral amyloid angiopathy, this is a disease of older patients, okay? The mean age of diagnosis is around 67. This is not a diagnosis that I entertain in patients under the age of 65. I'm sure there are some outliers that are in their younger 60s that have it, but in general, this is a disease of older patients. Just like conventional cerebral amyloid angiopathy, this has a slight male predominance, about 55% of the time seen in men. And this has a variable presentation. These patients may present with cognitive decline. In fact, cerebral amyloid angiopathy, there's a bit of an overlap with Alzheimer's disease. These patients can also have seizures, headaches, stroke-like symptoms. Interestingly, in the inflammatory cerebral amyloid angiopathy, having an outright parenchymal hemorrhage or hematoma at time of initial presentation is less likely than in conventional cerebral amyloid angiopathy, but definitely be looking for those foci of gradient susceptibility because they typically will have those. I have one case that I've seen in which they had absolutely no hemorrhage, no evidence of blood products whatsoever, went to biopsy and was found to be inflammatory amyloid. But in general, I think that we see the foci of gradient susceptibility in most of the cases. But importantly, this is something that is treatable to some degree. It's not going to correct it. It's not going to cure it. But these patients are given steroids. Sometimes they've been put on immunosuppressive agents, and that really knocks down the inflammatory response. So it's an important diagnosis to think about because it's something that potentially can be treatable. So I think this is a worthwhile paper for all the residents and fellows out there to take a look at. This is a fairly recent review, systematic review of cerebral amyloid angiopathy, particularly the subtype that's associated with inflammation. This was published in 2018, and it's a pretty quick read, so worth taking a look at for sure. Okay, so to wrap this up, this was a case of cerebral amyloid angiopathy-related inflammation. And the key imaging features to keep in mind as you approach this diagnosis: look for those multifocal dots of gradient susceptibility. Most of the time you'll have evidence of this. Like I said, I've had one confirmed case in which there wasn't a bit of blood, but in general, you're looking for these supratentorial and peripheral foci of gradient susceptibility. It can be associated with lobar hematomas and subarachnoid hemorrhage, so keep that in mind as well. And what really separates this particular inflammatory subtype is the fact that you'll find these coexistent T2 and flare hyperintensities representing vasogenic edema. You may also see enhancement if you give contrast. A couple pitfalls to keep in mind. Again, I want to stress that this is a steroid-responsive disorder, so don't forget about this. This is a potentially treatable cause of altered mental status and cognitive decline in older patients. It's not going to cure the underlying cerebral amyloid angiopathy, but it will take down the inflammation, and patients will have some important symptomatic recovery. And then it's also important to keep in mind that these, unlike hypertensive microhemorrhages, tend to have a different distribution in terms of where you find them within the brain. So hypertensive microhemorrhages are more commonly going to be central, may involve the basal ganglia, the brainstem. That doesn't mean that cerebral amyloid angiopathy cannot, but more characteristically, we see this supratentorial and peripheral. So if you see a patient that has a striking central distribution to the microhemorrhages, be thinking about other etiologies like chronic hypertension. And then lastly, I want to stress clinical context is key here. These really need to be older patients, probably patients over the age of 65 who show up with spontaneous bleeds and inflammation. This is not a diagnosis that I lead with in a patient who's previously had radiation therapy, because those patients can certainly have radiation-induced injury in which they get microhemorrhages, edema, curvilinear enhancement. So make sure that you're familiar with the patient's backstory. If they have a history of prior whole brain radiation or even targeted brain radiation, I probably would not swing for the fences calling cerebral amyloid angiopathy, because they have such a high likelihood that it's due to radiation-induced injury instead. And then lastly, again, stressing this is a diagnosis of older patients. This is not something that we typically would even think about in a patient who's younger than age 65. As always, thanks for tuning in to IU Radiology Case of the Day. You can follow along on Twitter at NAKuntz, and I would invite you to check out the complete collection of IU Radiology Case of the Day materials. They can be found at radtf.iuhealth.org/COTD. Thanks so much.